examination, respiratory examination. For respiratory examination, the exposure is all of the chest exposed. The position is supine position. At some stage, you need a patient to sit to examine from the posterior. So, with the patient in the anatomic position, you start by doing a quick general examination. Your general examination should capture the aspects that are relevant to the respiratory system. So, check for temperature, look up, check for pallor. You look at the nostrils, whether there are flaring nasal. Open your mouth. You look out for central cyanosis and pallor. Lift up your tongue. Okay, let me see your tongue. You also look out for dehydration. Then after that, you look at the fingers for finger clubbing, which is a general examination feature sometimes you find in respiratory diseases. After that, that should be enough for quick general examination for respiration. You now come to the chest and focus on the respiratory system. You follow inspection, palpation, percussion, and auscultation. For inspection, you start by looking at the anterior chest and observe for symmetry or any obvious lesion, any obvious swelling, or some abnormal movements. So you look at the symmetry of movement in both hemithorax. After that, you conclude inspection by checking the respiratory rate. To check for the respiratory rate, you put your fingers on the pulse and you count the respiratory rate. This is to distract the patient. For the patient to think you are counting the pulse, but you are counting the respiratory rate. You count the respiratory rate for 1 minute. Then after that, you go on to palpation. Palpation starts with checking for trachea position. Let the patient be facing forward. Your right index finger in the medial border of the right clavicle, your ring finger in the medial border of the left clavicle, and the middle finger palpates the trachea, whether there is deviation. After that, you palpate for tactile vocal fremitus. You divide the lung zones into 3, upper, middle, lower, and you compare each side one after the other. You don't do all of the left before you come and do all of the right. No. So if I want to do tactile vocal fremitus, I place the ulnar border of my hand in one intercostal space in the upper zone and ask the patient to say a word that will reverberate like 99. Please say 99. 99. Then you compare the other side. Say 99. 99. This is the upper zone, middle zone now. Say 99. 99. Say 99. 99. Then the lower zone. Say 99. Say 99. You also check the lateral aspects. On the upper side, say 99. Say 99. Say 99. Say 99. And then the lower, say 99. 99.
You will look me. You will look my way before you talk.
Are you with me?
Yes, sir.
Then after that, you check for chest expansion. You also check the 3 zones. You spread out your hand over the chest wall and let the thumb meet at the midline. First, the upper lung zone. Breathe in and out. In, out. You check the middle zone. Breathe in, out. So you see the expansion. If there is a problem on one side, that side will not expand like the other. Then you check the lower zone. Breathe in, out. Okay. After that, we are done with palpation. We now go on to percussion. For percussion, like we did before, share the lung into 3 zones and the sides, and percuss comparing both sides. So first of all, upper zone, you percuss. In percussion, the movement should be at the wrist joint. You use the middle finger against your left middle finger, the middle phalanx. So you percuss, you compare upper to upper, middle to middle, lower zone to lower zone. Then the sides, upper, middle, then lower. After that, you auscultate. You auscultate also these same zones. You listen here, you compare to this. Middle, lower, side upper, side middle, side lower. After that, we are done with the anterior chest. You now ask the patient to sit up. You ask the patient to sit up. And you examine the posterior chest wall. In the posterior chest wall, you are not expected to repeat everything you've done on the anterior. 3 things you will do. You check the tactile fremitus, you percuss, and then you auscultate. So you ask the patient, say 99. Because the scapula are on the outer lateral aspect, you dwell close to the midline. Say 99. Then you percuss. Always comparing sides. And finally, you auscultate. You ask the patient to breathe in and you listen for the vowel sounds.
The breath sounds.
Whether they are normal vowel sounds or abnormal
breath sounds.
Breath sounds. You listen for breath sounds. Whether they are normal breath sounds or there are abnormal breath sounds. Thank you. Examination demonstration session. Patients are examined on the right hand side of the patient. We start with general examination. Before you examine a patient, you greet the patient and introduce yourself and obtain permission. Good day, I'm Dr. Hendricks. How are you? Please, can I examine you? Thank you. Then after that, you position the patient and ensure the patient is well exposed. For general examination, you need the patient to be exposed. And the position is the anatomic position, which is supine position in bed, with the patient supine, the palms facing upward. General examination starts with inspection. Are you with me?
Yes, sir.
Inspection, you look at the patient from the head to the toe. You note whatever you can see on the patient. You look at the patient's general outlook, the estimated age range, whether the patient is a young man. When you think the age is below 40, is middle age, between 40 to 60, is elderly from 60 and above. And then you look at the general health status, whether the patient is acutely ill, critically ill, chronically ill, or is not ill looking. And then you also note like an infusion that is in situ. You note the type of cannula and what type of infusion is running. If a patient has a catheter, you also note it. So after the general inspection, you now start the specific examinations for general examination. It's good to walk from the head down to the toes. So we start by checking the hair texture, whether there is fluffiness. Is that clear? Then after that, with the dorsum of your fingers, you check for warmth, and then use the tongue to lower the lower eyelid and look for conjunctival pallor. Then after that, with your left hand, the thumb and the index finger on the upper eyelid, you raise up the upper eyelid, bring your right finger, ask the patient to focus on your right finger. Look at my finger. Look at it, follow it. Then you look at the sclera for jaundice. After that, you come toward the mouth, you look at the nose and see whether there is flaring. Then in the mouth, you ask the patient to open the mouth. Bring out your tongue. Raise up your tongue. Raise it up. Okay? 3 things you look out for in the mouth. You look out for cyanosis, you look out for pallor, and you look out for dehydration. You look at the tongue, you look at the buccal mucosa for pallor. You look at the tip of the tongue for central cyanosis. And you look at the surface of the tongue for wetness to determine whether there is dehydration. After that, remember we are working from the head downwards. After that, we now check the lymph nodes in the neck, whether they are palpable. You can do that by asking the patient to sit up, or you can also do it with the patient in the lying position. If we were to do it in the lying position, you go systematically. Start with submental, submandibular, pre-auricular, post-auricular, raise your head, occipital, and then cervical upper group, cervical middle group, cervical lower group. Shrug your shoulders, and then you check supraclavicular. Another way to do that is to ask the patient first, sit up, and then you come behind the patient and check submandibular, preauricular, upper cervical, middle cervical, lower cervical. Raise your shoulders. Supraclavicular, then post-auricular and occipital. Some people, when they want to do post-auricular, come in front of the patient and do post-auricular like this and occipital like this. It's all accepted in such all the demonstrations we have shown. Is it clear?
Yes, sir.
Right. Then after that, in general examination, we come to the axilla. To check the right axilla, you shake the patient with your right hand, abduct the axilla, and place the forearm over yours to relax the muscles. Then systematically you palpate the 6 groups of axillary lymph node: the medial group, the anterior group, the posterior group, the lateral group, the central group, and you dig in for the apical group. After that, for the left, you shake the patient with your left hand, abduct to expose the axilla, rest the patient's forearm on yours, check the medial group, the anterior group, the lateral group, the posterior group, the central group, and the apical group. Some people, when they want to check the lateral group, they change hands and use the other hand to check the lateral group. Whichever method you do, they are accepted. After that, you check the epitrochlear group. You feel for the olecranon and dig your fingers into the epitrochlear regions and feel for lymph nodes. You also check on the other side. Then now we are in the palm. You pick the hands up and first of all look. In the hands, you first of all check for palmar pallor. Assuming you are not anemic, you compare the patient both palms with yours. Then after that, you turn the dorsum of the hand and you look at the fingers at the nail bed for peripheral cyanosis. Then you check capillary refill by pressing on the nail and looking. Once you press on the nail, there'll be blanching. Then you see how long it takes for it to become red again. It should be a matter of a second or two for normal capillary refill. Then after that, you squat by the patient bedside and look out for finger clubbing. You look at eye level for finger clubbing. If you do find, you characterize it and stage it. Then after that, we are done with the hand. We are now at the groin. We are working general examination from the head. So just you expose the groin and you palpate the inguinal group of lymph nodes. After that, we come to the popliteal. You flex the knee, dig your fingers into the popliteal space and palpate for popliteal lymph nodes. Then finally, Not finally though. We are now at the feet. Here you check for pedal edema. First of all, apply pressure on the dorsum and see whether there is edema. If not, you go to the malleoli, apply pressure and rub and see whether there is edema. Once there is no edema at the level of the malleoli, there is no reason to continue. But if there is edema, you continue along the pretibial region where the tibial bone is prominent and continue to check up to the knee and sometimes even beyond to the level of the edema. The last thing on general examination, especially for a patient who has been in bed for some time, is to check for the pre-sacral edema. That's the end of general examination. Thank you. Cardiovascular examination. Here, the positioning is the cardiac position. The cardiac position is such that the head of the bed is placed at 45 degrees. So before you start cardiovascular examination, the examiner should see you adjust the head of the bed to 45 degrees. Then after that, you make sure the patient is well exposed, the whole of the chest and the feet, the leg, they are exposed. This is how cardiovascular examination is done. First, you do a quick general examination and examine those aspects of general examination that are relevant to the cardiovascular system. Then you examine the pulse, followed by the blood pressure, followed by the jugular venous pressure, followed by examination of the heart, and you end up by checking for the basal breath sounds. So for general examination, again, we check for temperature, look up, we check for pallor, open your mouth, we check for cyanosis and pallor, and then we check for dehydration. Then you check the digits for finger clubbing, you look at eye level, and then you check for pedal edema. The aspects of general examination relevant to cardiovascular system. After that, we move on to the pulse. You check the pulse, you check the rate, you check the rhythm, you check the volume of the pulse. Then you check for synchronicity, radio-radial, and then you check also radiofemoral. That is sufficient for the pulse analysis. Then after that, you check the blood pressure. You make sure the sphygmomanometer is placed at the heart level, and the cuff size is such that covers 2/10 of the arm. You apply the cuff. After applying the cuff, You first of all feel the radial pulse. Then you inflate the cuff gradually till you can no longer feel the radial pulse, and you take it 20 to 30 millimeters of mercury above that. Then you let it, you reduce the pressure slowly till the first time you feel the pulse again. And this is the manually estimated systolic radial blood pressure. Then you use the stethoscope. You place the diaphragm on the medial aspect of the cubital fossa, where the radial artery is located, where the brachial artery is located. Then you inflate again above what you have got from the manual palpation of the radial pulse. Then gradually deflate. The first sound you hear will signify the systolic blood pressure. And then at the point the sound muffles, you have the diastolic blood pressure. After checking the blood pressure, you proceed to check for the jugular venous pressure. This is how you go about it. You ask the patient, please turn to that way, and then you inspect the right side of the neck. If there are pulsations, or rather oscillations of the internal jugular vein, you get two rulers, one at the level of the heart and then the other at the height of the one at the sternal angle of Lewis, and then the other at the height of the pulsation. And then you read from the one at the sternal angle of Lewis. But most surgical patients may not have elevated jugular venous pressure. We now go to the heart. First of all, you inspect the precordial area for any visible precordial activity. If you see, you note it. If not, you go on to palpation. Palpation starts by placing your palm over the region of the heart, the precordial region. Then, as you feel the heartbeat, you try to locate it with your fingers to locate the apex beat, the most prominent beat. Once you locate it, you have to define the anatomic position from the clavicle and the intercostal space. Let's start with the intercostal space. Run your left fingers along the sternum till you feel the sternal angle of Lewis. Then below, you trace it toward the rib. The rib attached to it is the second rib. Then the intercostal space below that is the second intercostal space. Then you begin to count. This will be third and this will be fourth. Then you trace it toward where the apex beat was located. Here now it is the fourth intercostal space. Then you trace this toward the clavicle. It is mid-clavicular line. So you have to locate the anatomic position of the apex beat. After that, you auscultate for heart sounds. You start at the apex beat. First of all, listen with the diaphragm. After listening at the apex beat, here you are listening for the mitral valve, the sounds produced at the mitral valve. Then you listen at the lower left sternal border for sounds produced from the tricuspid valve. Then you locate the sternal angle of Lewis again, trace it to the left, the second intercostal space on the left. You listen for the sounds produced in the pulmonary valve, and then you trace it to the right, the second intercostal space there for sounds produced from the aortic valve. You listen again at all these sides with the bell of the stethoscope. You listen for the out sounds, and you listen for any other additional sounds like murmurs, a third heart sound, and so on. Finally, you ask the patient to sit up, and you listen at the lung basis for fine crepitations you could find in pulmonary edema related to left heart failure. Thank you. Thank you so much.
Thank you, sir.
Very good.